Welcome to part 2 of diabetes. This part is going to focus on the physical assessment and the diagnostic assessment for diabetes. There are 3 hallmark symptoms of diabetes. They are dependent on the level of glucose, with the higher levels of glucose causing worse symptoms. The hallmark symptoms are polyuria, or frequent urination, polydipsia, which is frequent thirst, and polyphagia, which is frequent hunger. Polyuria and polydipsia occur due to the osmotic diuresis occurring from the hyperglycemia. They can lose a lot of fluid and the body gets thirsty and dehydrated, so they drink a lot. And by frequent, I mean it's almost non-stop peeing and drinking. Polyphagia occurs from the catabolic state caused by the insulin deficiency and the breakdown of fats and proteins for energy. Basically, the cells are starving and they're trying to survive. They tell the brain to eat. In addition to these hallmark symptoms, diabetes may have fatigue, weakness, vision changes, tingling or numbness in the hands or feet, dry skin, skin lesions and wounds that are slow to heal, and recurrent infections. These are all the symptoms of long-term hyperglycemia, but many people don't even know they have diabetes until one of these issues occurs. They go to their provider, they get checked out. So it's always really good that we watch out for these things in our patients. In type 1 diabetes, of course, we get those 3 hallmark symptoms. But in addition to these, we may have sudden weight loss because the body is starving, so they start to lose weight really quickly. Type 1 diabetics are more prone to complications like vision changes, fatigue, wound healing issues, circulation issues, numbness and tingling in the hands and feet because they don't make any insulin, so they're always in a constant state of hyperglycemia, and that hyperglycemia is causing the complications. In type 2 diabetics, we get the same symptoms as type 1, but they're usually much slower to have their onset because the cells are not totally starving to death, so they don't get that rapid weight loss like they do in type 1 diabetics. They can lose weight, but it's not rapid. It's not like losing 10 pounds of weight in a week kind of thing. And all their symptoms just seem to have much more slower onset. To diagnose diabetes, there's very specific criteria, so we're going to move on to that next. The first diagnostic criteria we have for diabetes is fasting blood glucose. Fasting means nothing to eat or drink for at least 8 hours prior to the blood being drawn. A fasting blood glucose of 126 milligrams per deciliter or higher is diagnostic for diabetes. However, the provider doesn't usually just take one fasting blood glucose level that's elevated and diagnose diabetes. Usually they're going to repeat it or they'll do more testing. Another test providers can order is a random or causal blood glucose. This is when they draw a blood glucose level that has no regard to when they ate or drank last. For this to be diagnostic, the level must be greater than 200 milligrams a deciliter, and there must be symptoms of hyperglycemia. They can also do a post-glucose ingestion blood glucose test or postprandial, where we have the person ingest 75 grams of glucose and we check their glucose levels 2 hours later. For this to be diagnostic, the blood glucose level must be 200 milligrams per deciliter or higher. We do this test in all pregnant people to check for gestational diabetes. However, the most accurate type of diagnostic criteria we have for diabetes is a hemoglobin A1C, sometimes called a glycated hemoglobin. I'm going to discuss this in depth on the next slide. So the most accurate diagnostic we have for diabetes is a hemoglobin A1C. Hemoglobin A1C measures the amount of glucose that is attached to a hemoglobin cell. And because hemoglobin cells live for 2 to 3 months, a hemoglobin A1C level gives us the best idea of what the blood glucose levels have been over the last 2 to 3 months. It's not affected by fasting, and it's not inaccurate because of when you last ate. It's telling us your blood glucose over time. If you look at my chart, a hemoglobin A1C of 6.0 is roughly equivalent to an average blood glucose level of 135. If we have a person with a hemoglobin A1C of 6.5 or higher, That is diagnostic criteria for diabetes. If their A1C is 5.7 to 6.4, they are considered pre-diabetic, meaning they need to make some life changes quickly to stop diabetes from occurring. If we have someone who's diabetic, we will check an A1C every 3 months to see how well their diabetes is being managed. They're going to use this lab value to change medications as well. The goal for a diabetic is to get their hemoglobin A1C less than 6.5. And this morning, I was in SIM and there was a story about someone that one of the people in SIM knew their hemoglobin A1C is running 14%, which is an average daily blood glucose level of over 400. So it's very, very high. So I mentioned that we can evaluate our patients' lab values to see how well their glucose is being controlled. So when we do that, we want to see a fasting blood glucose level between 70 to 80, a random or causal or post-glucose blood glucose below 200, and a hemoglobin A1C less than 5.7. If we don't have those numbers, the provider may change the medications they are taking or may encourage better diet and exercise routines. And this is the end of part 2 of diabetes.